Hello, everyone. Welcome back to the Radiology Advances podcast. If you've ever dealt with scheduling a neuro MRI for a challenging patient, you know the headache. It's often not the scanner itself, but the time it takes. Those long acquisitions, they lead to motion artifacts and bottleneck the department. And sometimes, well, they come with sedation, especially for kids or really sick patients.
It's a huge logistical hurdle in neuroimaging. We've always sort of looked to hardware for improvements, but what we're digging into today, it suggests the real revolution might be happening in the software, in deep learning, to be exact.
Right. And we're looking at a study that really puts this to the test head-to-head with actual clinical data. It's titled Deep Learning MRI, halves scan time and preserves image quality across routine neuroradiologic examinations.
This article, published in Radiology Advances by Sean K. Lyo, Suyash Mohan, Alvand Hassan Khani, and colleagues from the Hospital of the University of Pennsylvania and the Thomas Jefferson University Hospital in Pennsylvania, United States, were examining exactly that comparison.
Okay, so our mission today is pretty clear. Let's unpack what they found comparing deep learning accelerated MRI, referred to as DL-MRI, with conventional MRI or CMRI. And we're looking across a whole range of everyday neuroscans, ranging from the brain to the lumbar spine. We'll try to understand where DL-MRI fits, how it stacks up on efficiency, and crucially on image quality.
And the study setup was quite solid. They looked at 113 different sequence pairs from 26 patients, all done on a Siemens 3T Magnetome Vita using their Deep Resolve algorithm.
Let's jump straight to the big headline then. Efficiency. You hear whispers about cutting scan times in half, but does that actually hold up across the board in a real clinical setting?
Well, the headline number is pretty staggering. DL-MRI slashed the mean scan time by 51.6%. That's huge. The average scan dropped from about 110.8 seconds, so nearly 2 minutes, down to just 53.7 seconds across all the sequences they looked at on average.
Wow. And the clinical motivation for that is obvious, isn't it? Less time means less chance for movement, fewer repeats.
Potentially less need for sedation, better patient experience, better throughput for the department. It ticks a lot of boxes.
How did this deep resolve algorithm manage to cut the time so drastically without just throwing away half the useful information?
Fundamentally, it's about acquiring less data up front, but then using sophisticated reconstruction to make up for it.
Okay, so acquiring much less raw data, faster scan, but more gaps to fill in.
Exactly, and you're relying on the Deep Resolve deep learning network, which has been trained on tons of images to intelligently fill those gaps. That uses things like wavelet space, denoising, and learned reconstruction techniques to enhance resolution and maintain quality even with that sparser input. They also cut down the number of signal averages, basically how many times you measure the signal for each data point, dropped from about 1.88 down to 1.11, another way to speed things up.
Makes sense. Now, you said the average time saving was 51.6%, but I remember seeing the savings weren't uniform across all scans.
That's right, it definitely varied. The biggest time savings were actually seen in sequences looking at the sella, the pituitary region, and also sequences taken in the coronal plane tended to show bigger time reductions compared to axial or sagittal planes.
If you cut scan time in half, the gut feeling is quality must take a hit, right?
That's the elephant in the room, isn't it? And that's what they tested rigorously. They had 4 neuroradiologists, 3 attendings, 1 fellow, so experienced readers, look at the images side by side. Paired images, of course, they didn't know which was DL and which was conventional, were presented to the readers side by side. They rated them on a 5-point Likert scale, either favoring one of the images or calling them equivalently good.
And what did the raw preference scores show? Do they lean towards the faster DL-MRI?
They did slightly. The mean overall preference score was 3.56, and for a signal-to-noise ratio, it was 3.51. So numerically, just a little nudge above 3, favoring DL-MRI.
Okay, so if the average score was slightly favoring DL-MRI, why isn't the main takeaway DL-MRI is slightly better and much faster? Why the emphasis on equivalence?
This is where we need to look beyond the simple average. It's a really critical point for anyone interpreting these kinds of studies. The key was the inter-rater reliability, measured by interclass correlation, ICC.
Right, the ICC. How much the readers agreed with each other.
Exactly. And here, the ICC was, well, it was low, really low, ranging between 0.64 and 0.329 across the different quality metrics.
Indeed, that is low. So what does that practically mean?
It means the readers often disagreed significantly on which image was better. One reader might score a DL sequence of 5, strongly preferred, while another reader, looking at the exact same comparison, might score it a 1 or a 2, preferring the conventional one. That lack of consistent preference, that disagreement, it strongly argues against saying one is definitively better. Instead, it supports the conclusion of functional equivalence.
So the slight average preference towards DL is almost misleading because there was no real consensus behind it. The readers couldn't reliably agree it was better.
True. Despite the massive speed up, the images were, for diagnostic purposes, effectively interchangeable in the eyes of these expert readers, even if individual subjective preferences varied wildly.
Okay, functional equivalence established. But as you said, equivalence doesn't mean identical. Did the study dig into which specific sequences performed best or worst with DL?
Yes, brain axial T2 images had the highest overall reader preference score at 3.89. And cervical spine axial T2 also scored well on preference and had huge time savings, being around 67% faster.
So T2 seems like a possible sweet spot for this DL acceleration.
It really seems to be based on this data.
What about the other end of the spectrum? Were there sequences where DL maybe didn't perform as well, relatively speaking?
The one that stood out with the lowest preference score was the thoracic sagittal STIR sequence. Its score was 3.12.
This brings us to the more subtle qualitative differences. The readers left comments, right? Did they notice specific things that looked better or maybe worse on the DL images, even if the overall rating was similar?
Yes, and this is crucial for clinical interpretation. Sometimes the DL processing actually enhanced certain features. For instance, readers noted better visualization of the central vein sign in the brain on T2, FLAIR, or FAT-SAT images. That's relatively important for diagnosing MS.
Oh, interesting. So a potential diagnostic plus there?
Potentially, yes. And similarly, on post-contrast T1 images of the spine, they felt the posterior median spinal vein was easier to see with DL. Again, helpful for certain vascular conditions.
So, some gains in visualizing smaller vascular structures may be due to the enhanced sharpness.
That seems likely, yeah. But there was a trade-off. The main drawback mentioned was less conspicuous gray-white matter differentiation, especially on axial T1 weighted brain images.
Okay, that's a potentially significant downside depending on the clinical question, right?
Absolutely. If you're looking for subtle cortical dysplasia in an epilepsy workup, for example, that reduced differentiation could be a problem. You might want to stick with conventional sequences for that specific purpose.
But for an MS protocol where the central vein sign is key, or maybe routine spine where speed is paramount,
DL-MRI might be the better choice. It really points towards tailoring the protocol based on the clinical indication.
makes sense. What about artifacts? Did the DL introduce new problems or change how existing artifacts look?
Both, actually. Overall, the mean artifact rating didn't show a significant preference between DL and conventional, but the types of artifacts were different. Firstly, some conventional artifacts seemed more obvious on the DL images, things like CSF pulsation artifacts on sagittal spine T2s, probably because the overall image was sharper, making the artifacts stand out more. And secondly, there were new artifacts specific to the DL reconstruction. Readers noted things like vertical banding in the phase encoding direction, particularly in the spine, and also more prominent Gibbs ringing artifact in the spinal cord.
So radiologists need to learn a new set of potential pitfalls specific to DL images.
Definitely. You need to be aware of what these DL-specific artifacts look like so you don't misinterpret them as pathology.
It really screams hybrid approach, doesn't it? Use DL where it works best. Maybe for those T2 sequences where preference was high and time savings were huge, but maybe hold off on sequences like STIR, depending on the context until there's more data or further optimization.
That seems to be the clear implication.
And it also opens up possibilities beyond just reducing scan time, right? You could reinvest that saved time.
Exactly. That 51.6% saving doesn't have to mean a 51.6% shorter appointment. You could use that time to, say, acquire images with thinner slices for better resolution. It gives you flexibility.
Okay, let's try to synthesize this. The core takeaway for you, our listeners, seems to be this. Deep learning really did deliver on that promise of roughly halving neuroscan times. And critically, this speed came with functional equivalence in image quality overall. It wasn't consistently better, but it was reliably interchangeable for diagnosis.
Which is potentially a big win for patients. Less time in the scanner, potentially less sedation. And for departments, much better throughput and efficiency.
But we have to acknowledge the caveats too.
Definitely. This was one study at one center using one vendor's 3 Tesla scanner and algorithm. To really know how well this applies everywhere, we need more research, different vendors, different field strengths, and we need larger studies to really nail down those optimal hybrid protocols for different clinical scenarios.
Thank you for joining us for this Radiology Advances podcast. Thanks to Sean K. Lyo and colleagues for publishing with Radiology Advances. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Luca Salifer from the University Hospital Essen, Germany, for accuracy.